A little bit about the historical development. First hysterectomy was a vaginal hysterectomy for prolapse, was done in 1813. Then 1843 is a abdominal hysterectomy, and the first laparoscopic hysterectomy was done in 1989. So if you compare in the Western world, USA is almost 1/3 of women at the age of 60, they would have had hysterectomy. As compared to UK and Australia, it's only 17%. So they do really far more than us. It's like 600,000 per year in 2011. So why is hysterectomy performed? So for several reasons. One is pelvic support problems. There can be a prolapse, or it can be due to abnormal uterine bleeding, can be asymptomatic fibroids, it can be endometriosis or chronic pelvic pain, or can be gynecological cancers. So are there any alternatives to hysterectomy? This is the main important one, because the patient comes with prolapse, whether they can be managed with a pessary or conservative management. Say if the patient comes with a prolapse and it's just a mild prolapse, they can be managed conservatively. So pessary, so like a very old patient, or those who don't like surgery, or they're not fit for surgery, so can be managed with a pessary. So usually we normally encourage patients who are having prolapse, young, active, have a active, they're sexually active, and so those patients, they are more suitable for a surgical management. So they will benefit with a vaginal hysterectomy. So abnormal uterine bleeding. So we have a lot of non-invasive methods are there, such as Mirena, endometrial ablation. So those are first line of less invasive methods, because Dr. Kishore was talking about medical management. So if medical management fails, we can try this. There's significant improvement with these ones are there. So if it's not responding, then we can go for the definite management like hysterectomy. So fibroid uterus, most of the fibroids, they are not symptomatic. They are just there. They are mostly benign, so can manage conservatively. And we have, if it goes into the cavity, we have now a new technique called MyoSure, which is available in Bendigo. So if it's a submucosal fibroid, we can just take the fibroid only, shave the fibroid, so their symptoms can get better at it. So the other one is GnRH analogs. It's not a definite treatment, it's just to delay or make the uterus shrink.
And what about that technique of cutting off the artery to the fibroid, that radiological technique?
That is like it's not, we are not doing, I don't think we have that service here.
No, we don't do embolization.
Embolizations,
so you're asking about fibroid embolization, we don't provide that here.
Yeah.
There's a few sort of fancy things, and I know there are a few that the women's have tried. There's an MRI treatment of fibroids as well, but we're not participating. Marshall's really good though. Good on her.
So the other one is for endometriosis and chronic pelvic pain. So this is the one most of the patients come and they ask for that. They come just straight away because it's enough for me. It's having a lot of pains. I can't use hormones. I can't use other things because it's disturbing my mood. My depression is getting affected. My anxiety is getting worse. So I want hysterectomy. They come and ask. So there is a role for that, but we always tell the patients, because hysterectomy is not a guarantee that their pain symptoms will completely go away, right? But like if there's adenomyosis, or sometimes because of chronic pelvic pain, sometimes they can respond, but we don't do as a first line, just normally after trying everything. But the patients need to understand, but it's not a definite answer. Sometimes even after surgery, the pain can get worse also. So gynecological cancers, even they are now sometimes treated with chemoradiotherapy rather than like an early stage cervical cancer. It's equal prognosis with chemoradio and surgical. So what structures are removed during hysterectomy? So the total hysterectomy is uterus including the cervix. Total hysterectomy with bilateral self-injectomy is uterus and tubes. Total hysterectomy, bilateral self-oophorectomy is tubes, ovaries, and the uterus. Supracervical or subtotal is upper uterus removed, cervix is left. Radical hysterectomy, we don't do that, it's done in the cancer center. So they do total hysterectomy and structures around the uterus is removed. So how can hysterectomy be performed? There are different ways there: vaginal, abdominal, laparoscopic hysterectomies. Even with the laparoscopic we have LAVH, TLH, and more advanced one. I will come to that later. So decision to perform a certain method of hysterectomy depends on several factors. So mainly first one is experience and level of comfort with a particular surgical approach. Because we have different surgeons are there, sometimes they are very happy with their pelvic floor surgeons, so they really like to do vaginal hysterectomies. Some are more experienced with laparoscopics, it can be laparoscopic approach, or sometimes with the abdominal approach. And also depends on the patient condition, and the pathology. If the patient is very obese, so, and a lot of medical comorbidities, so very likely she's going to have an abdominal hysterectomy. So they should know that it's a difficult, big surgery. So they are, going to be, recovery is going to be very long. So it's a lot of factors are there. So it's not, because sometimes, the patient thinks like anyone can have a laparoscopic approach or less pain. It's not like that. So, and also depend on the pathology also. Say if the patient is having obvious prolapse, so then it's okay, they can have a vaginal hysterectomy. Otherwise, if the patient is having a ovarian pathology there, or if the uterus is not descent or something, then they will have to have an abdominal or laparoscopic approach. And indication for surgery and available facilities, because not all the gynecological centers can do advanced surgery, because it needs it's actually a trained staff to work as a team to do a certain advanced type of hysterectomies. So just put a picture here. Vaginal hysterectomy is just a starting, this is the way they start, because here they're using a diathermy just to do a circumcision, and then from that, they will dissect the bladder and the rectal area, the vaginal wall, and then do the hysterectomy. So here uterus is removed through the vagina, no abdominal incision is done. So indication and suitability is they should have a uterine prolapse, at least first to second degree prolapse should be there. Size of the uterus ideally should be less than 12 weeks. They should have enough vaginal access should be there. So if the patient is nulliparous, a narrow, long vagina, so then she's not suitable for vaginal hysterectomy. And should have a uterine mobility should be there. If it's like a frozen pelvis or had some pelvic pathology, then it's very unlikely she's going to get a vaginal hysterectomy. There shouldn't be no significant abdominal adhesions, so no known adnexial pathology, and also depends on the experience of the surgeon. So benefits of vaginal hysterectomy, it's the least morbidity of all types of hysterectomy. So that's one of the best one. So morbidity-wise, vaginal hysterectomy is the least compared to laparoscopic hysterectomy, and the abdominal hysterectomy is the most morbidity. That means the recovery time is more. It takes more time with the abdominal hysterectomy. So bleeding is usually less than abdominal hysterectomy. Time duration is usually 1.5 to 2 hours. The hospital stay is usually 2 to 3 days. Healing is shorter than abdominal, and they have a quick recovery. So ureteric and bladder injuries are it's much lesser, because much safer, because you retract away from the uterine artery pedicle before putting the pedicles. So the chances of injuries are very, very minimal. Even if it's injury, sometimes you might get a bladder injury when you're dissecting the plane, but you obviously see that and you easily can repair it. So we come to abdominal hysterectomy. So it's done either midline or just a suprapubic transverse incision, depending on the size of the uterus and the other pathology. And we are worried about some other difficulties going to happen, like having a complex big ovarian mass or something. So we might worry because we have to have the surgeons involved, so they prefer a midline surgery. So in that case, the recovery is going to take more, the morbidity is more. So uterus is removed through an incision in the lower abdomen, most common hysterectomy, even in USA it's the most common. So the benefits is can do even with significant adhesions, it can do for any size uterus or fibroids, availability at centers with gynecology service. Anywhere we have the gynecology service, it's available. Most common option for obese and morbidly obese and patient with medical comorbidities. It's more suitable for large adnexial pathology and cancer pathology. Risk and issues: high risk of infection, and other complications such as bleeding, blood clots, nerve and tissue damage. So this is only really important because when you see a patient and when you talk about the patient, because a lot of patients sometimes they come and tell, because I have spoken to my GP, I have spoken to everyone, I need a hysterectomy, they come in straight away ask. So sometimes unfortunately, because they're very big, and like we're worried about this, not only the surgical thing, during the surgery, post-surgery, recovery, all those things, they can get problems. So sometimes they're not very keen to do less invasive method, they want straight away the hysterectomy. So if you know this is lot of issues are there with this, because they have a high risk of infection and other complications, you can at least counsel them and tell them, okay, you better try these ones rather than going for the definite hysterectomy, because you are very high risk. So blood loss is usually more than the vaginal hysterectomy. Time duration is usually 2 to 3 hours. Hospital stay usually 3 to 4 days. More risk than vaginal hysterectomy, ureter bladder injuries. Analgesia and recovery is more analgesia required, more time to recover. So laparoscopic hysterectomy, so the 3 types are there. One is a laparoscopic assisted vaginal hysterectomy, other one is a total laparoscopic hysterectomy, another one is a robotic hysterectomy. So the first 2 ones we do it here in Bendigo Hospital. So that is with a suitable patient. So normally you have a port in the umbilical port, you see the telescope, and then you make 2 or 3 incisions to send the other instruments like inertia devices and graspers, and then you do the surgery. So only requires...
Is the robotic surgery the same as the prostate?
Yeah, it's the same
robotic?
robot.
Yeah.
It's one of the big business cases is the fact that it's multiple use. So ENT is ENT, prostate and gynae would be the 3 uses.
Right.
Having just written business case.
So they only require a few small incision in abdomen, laparoscope inserted through the umbilical port to view the pelvic organs, other instruments used to perform surgery via other small incisions. Uterus removed via the vagina, less than 12 to 14 weeks, or removed in piecemeal by mosylation or bisection by large in size. Laparoscopic hysterectomy and vaginal hysterectomy needs more skill than abdominal hysterectomy. So it's getting more popular because ability to produce more hemostasis, can combine other surgeries at the same time. So we can treat adhesiolysis, treat endometriosis, or adnexial surgery, you can do it. Less post-operative analgesia, superior cosmetics, and minimal bleeding. Hospital stay is usually 1 to 2 days, low risk of infection. Return to normal activities much sooner than other hysterectomies.
And it's fun for the surgeon.
Fun for surgeon. Risk and other issues. It's a long learning curve. Risk of urinary tract injuries. That's a little bit risk. Ureter and bladder is higher than the other hysterectomy methods. Surgery time longer compared to other methods. This is due to several factors. One is depending on your learning curve, and not only that, anesthesia, because it's a long process, giving anesthesia, keeping both hands on the sides, they had to prep it, and then they had to position the patient in the lithotomy positioning, and then instrument setup, a lot of cables and wires, you had to all set up and all those things, and also recovery, so it takes a longer time. And it also depends on need a good teamwork for best outcome, so not only surgeon, you should have an experienced assistant, theatre nurse, really important because they know what you need. Because if they're experienced, they know, even if there's a complication, they know that what you need. So without asking, they will give the instruments. If it is a new one, new nurse or new assistant, sometimes they don't know the instruments. It's really difficult. It's a real struggle with laparoscopy. And the good anesthetist, because then they will tilt the patient, because the tilting is really important for to do the surgery easy. So if they tilt the patient like really 45 degrees, it will be really good to do the surgery, easy to do the surgery. So laparoscopic assisted vaginal hysterectomy is slightly less skill needed than for total laparoscopic hysterectomy, because this is like a middle of the learning curve. So you start with this, and then when you do more, then you go for total laparoscopic hysterectomy. Is upper pedicles, you do ovarian ligament, infundibulopelvic ligament, transcervical ligament release laparoscopically, with or without bladder dissection and uterine artery coagulation and cut. And rest is done through the vagina. And uterus is removed via the vagina and vault is closed. But also laparoscopic assisted vaginal hysterectomy is sometimes used when there is a uterine pathology with no descent, but there is a bladder and rectum prolapse. So it's no point going and doing a TLH for these patients. So these patients need the removal of the womb, and then you need to fix the bladder and rectal prolapse. So this one will have a laparoscopic assisted vaginal hysterectomy. So total laparoscopic hysterectomy is like a level 5-6 laparoscopic surgical skills needed. The whole procedure is done laparoscopically and uterus released via the vagina as a whole or bisected or moculated. Vault of the vagina closed laparoscopically. Cystoscopy usually done at the end to make sure ureteric jets visualized and exclude bladder injury. It's done, so this total laparoscopic and LAVH we do here when the patient is suitable and for appropriate indication. So this is the one talking about Da Vinci surgery. It's a robotic assisted. So you set up the patient in the table, you make incision in the tummy, and then put the ports, and then the surgeon and assistant, they use like they're doing in a console like thing, and they do the surgery. So very expensive, very high skill needed, because whoever doing this Da Vinci surgery will be really normally a very good high skill laparoscopic surgeons, then they go for do this. Hysterectomy performed with the help of robotic machine controlled by surgeon. Is no shown better outcome because it's comparatively it's same. Only proven benefit at this stage is surgery can be performed when a patient and surgeon living in different countries. So you can get, if a good surgeon in US, you can do it. If you have a center here, have that same instruments and sit, and they can do it from here. So different country in the future. So it'll be good in the future because you can save traveling and everything. Overall number of hysterectomies performed has reduced because of good pap smear, HPV test, colposcopy, so well advanced cervical screening program. So those days, when you have some cervical abnormality, you go for hysterectomy. Now it's all reduced. Effective treatment for precancerous cervical diseases, laser, LEDs, cone biopsies are there. And there is a publicized concerns that bowel, bladder, and sexual function may be affected with hysterectomy, which is true. You can get some little bit of alteration, but normally they get better, but it takes some time. Sometimes after hysterectomy, the patients have some different bladder, bowel function they might experience, but normally they get better after 6 months or 9 months. Other less invasive procedures to treat problems are menstruation, so Mirena, endometrial ablation, so the hysterectomy, the amount of hysterectomy we did about 10-20 years ago is significantly reduced now. That's all.
Thank you, Shobie.